All right, well, we'll get started. Good morning. It's my great honor and pleasure to introduce not just a great scientist and clinician, but also a great human being. Um, Dr. John Spertus is the Lauer, Missouri Endowed Chair and Professor at the University of Missouri, Kansas City, where he also serves as the Clinical Director of Cardiovascular Education and Outcomes Research at Mid-America Heart Institute. He is internationally recognized as a leader in cardiovascular outcomes research. He's authored more than 1,000 peer-reviewed publications, and his work has fundamentally shaped how we measure and improve the quality of cardiovascular care, and is certainly a star in my eyes. Dr. Spertus has developed a widely used patient-reported outcomes measures that has been used in many clinical trials and national registries. And he's also translated his scholarship into practice as the founder of several organizations dedicated to advancing personalized evidence-based cardiovascular care. So please join me in welcoming Dr. John Spertus. Take it away, John.
Thank you so much. It's really a pleasure to be here and to actually kick off your Grand Round season. I'll just tell a quick anecdote. After COVID, people really started participating in meetings and doing things so much more virtually and not really going to the meetings themselves. And you often forget that the opportunity for Brownian motion to allow you to interact and engage with others can be incredibly beneficial and fruitful. And I actually met Adam at a bar and the American Heart Association meeting. We just got to talking, and it's been really nice to forge a new friendship with a translational researcher where we have very different but synergistic research interests. And so for the younger of you who, aren't quite yet valuing the in-person participation in scientific meetings, I really want to encourage that. Please text and sign in so you get credit for this, because otherwise it's going to be a very tough hour to endure. I actually hope not, but these are my disclosures. I'm a consultant for a number of companies related to patient-reported outcomes. And far more relevant is the fact that, my career has been really devoted to elevating the patient-centeredness of care. And since fellowship, I've been developing several patient-reported outcomes, and I'll be talking about the Seattle Angina Questionnaire and the KCCQ throughout this discussion, and I hold the copyright to that, and we license it. The learning objectives I'm going to come to and show you at the end, as well as the link to the session evaluation. And so I want to start by just sort of presenting the aims of this discussion in the context of, if you had a brand new revolutionary test, a test that could define the status of a medical condition, it could improve the accuracy of its assessment, it could improve the efficiency of clinical practice in your care of patients as an outpatient, if it could risk stratify patients' prognosis, identify which patients benefit from treatment and by how much. It could monitor the response to treatments over time. It could support population health management and even define the quality of care. I mean, this would be a remarkable new test. And, for those old enough to remember Star Trek, it sounds like the tricorder that figured out everything when, Bones used it to evaluate injured people. But obviously, given the talk, I'm really talking about patient-reported outcomes. And PROs are trying to capture the patient's experience of their disease. So in coronary artery disease, as an example, there are abnormalities in atherosclerotic formation within the artery, physiologically restricting flow. There's abnormalities of vascular function. There's altered inflammatory status. And yet nobody feels the percent stenosis of their LAD. What they feel are the symptoms of angina. They feel the degree to which their angina impairs their physical, emotional, or social functioning. And the discrepancy between what their symptoms are and how they're able to function influences their quality of life. And so I like to use the example that if you had two patients, both of whom had weekly angina and had angina climbing more than a flight of stairs. But one was a 42-year-old construction worker. She might have a terrible quality of life because it impairs her ability to work. She doesn't have any friends that have this problem, and so her quality of life might be very poor. But the exact same symptoms and the exact same angina after a flight of stairs in a 72-year-old widower might not impair his quality of life very much because, frankly, he's doing better than most of his friends and he doesn't mind waiting for the elevator. And so, trying to capture and measure each of these concepts, which I think of as really the range of health status, the symptoms and function of quality of life, is very important. And that's what PROs, questionnaires, seek to do. And I'm not going to go through this, but there are a lot of psychometric requirements before you start using PROs in clinical practice or as outcomes in clinical trial. They have to be valid, meaning that, they are in fact measuring what you think they are. They have to be reliable. So if people are stable, the scores are stable. But conversely, they have to be sensitive to change. It's called responsiveness. You have to be able to understand what does a 5, 10, or 15-point change mean. And then if you're going to use it in different countries or cultures, you have to have translations available. So the Seattle Angina Questionnaire is a disease-specific quality of life or patient-reported outcome measure for coronary disease. It can be 19 or 7 items as a short version. And what it does is it essentially asks the kinds of questions that a clinician would ask about when evaluating a patient. How limited are they in their physical activity due to angina? How often are they having it? How is it impacting their quality of life? Has it changed recently? And are they satisfied with their current treatment? And then we have a summary score. Higher scores represent less physical limitation, less angina, higher quality of life. It's got very strong psychometric properties. It's in about 68 languages, and it's been associated with survival, acute coronary syndromes, costs. But importantly, these domains fall along the axis of quantifying health status that I described earlier. And, because I'm talking about it, it seems sort of very abstract, and I just want to make it very concrete for you. So this is the 7-item Seattle Angina Questionnaire. So the physical limitation scale asks, it has one sort of 2 to 3 med activity, one 3 to 5 med, and one greater than 5 med activity. And it asks how limited you are due to your chest pain, chest tightness, or angina over the past 4 weeks. Now, this is very similar to what you would normally ask in clinic, but the beauty is it asks it the same way every time, every patient. And so, we do a history very differently when it's, our first patient on a Monday than when we're an hour behind schedule Thursday afternoon and we haven't done our charting yet and we have to get home for our kids' back to school teacher conference. And so that's one of the advantages of directly asking patient. It asks, how often are you having angina? How often do you take nitroglycerin? And the quality of life scale, it asks how much it limits your enjoyment of life. And if you had to be this way for the rest of your life, how satisfied would you be? The KCCQ is very similar. It's a little bit longer, 23 or 12 items. And it also has summary scores that can integrate these different concepts. But, it's representing, unlike the New York Heart, the patient's perspective of their heart failure, not our assessment of how they're doing. It's available in about 130 translations now. The slide's a little old. And its psychometric properties are so good that both the drug and the device branches of the FDA have qualified it as a clinical outcome assessment so that if a new intervention, a drug or device, improves the scores on the KCCQ, that could be the basis of approval, even if it does not have an impact or a demonstrated impact on hospitalization or death. And like the FACC, it maps to these different conceptual domains. There's a clinical summary score that's meant to replicate the New York Heart Association classification. And then there's what I like, the overall summary score, capturing the totality of the impact of heart failure on patients' health. So let's go through sort of these different applications. The first is defining the status of a medical condition and improving accuracy. So when I was in medical school at the San Francisco VA, there were vets who'd had rheumatic heart disease, et cetera. And, when we were trying to figure out what was the physiology and anatomy of the heart, who was right? And it turned out to be the grayest haired clinician who would percuss the heart, listen to the murmurs, and basically tell us what was going on. And that obviously has some limitations in accuracy and reproducibility. It then came the echo, and now we have this objective measure of exactly what the anatomy and physiology is. Who defines the health status of a patient? It's usually the doctor assigning a New York Heart or Canadian Cardiovascular Society classification. And that's also going to have limitations in accuracy and reproducibility. And that's where I think PROs are going to have an increasing role. And, for clinicians, if you're seeing a patient in clinic and you can walk into the room and the patient's already filled out a sac and you know that they're asymptomatic and they had mild angina, monthly angina the last time you saw them, well, you know how you're going to frame that visit and you're going to be very proud of whatever intervention you made. On the contrast, if you have a heart failure patient and their KCCQ score was 80 and now it's 40, and they've got a lot more shortness of breath and physical limitation, you're going to approach that visit very differently because you want to immediately focus in on what's happened and what's changed rather than a lot of sort of the asking about their high school, their grandson's, high school graduation or something like that. And ultimately, what we're trying to do is understand how patients are doing from their own voice. And that can be challenging to do. And now, when I have sort of talked about the clinical use of PROs, doctors generally feel like, look, this is what I do. I do a great job getting patients history. That's our job. Well, so we did a study to ask, do doctors accurately assess angina? And so we took 24 cardiology practices in partnership with the ACC, and these were throughout the country. Each we said take the next 25 patients that come through your clinic, and what we'll do is we are going to try and understand from the patient's perspective. They are telling the doctor how much angina they have, but we got them to fill out the Seattle Angina Questionnaire. The doctors are interpreting what the patient tells them. And so we asked the doctors, did this patient have daily, weekly, monthly, or no angina? And then we compared the concordance between the two. Now, because angina is generally well controlled in cardiology practices, two-thirds of the patients had no angina, and the doctors did a great job assessing that. About a quarter had monthly angina, and about 10% had daily or weekly angina. And when you look at those patients where the patient is reporting that they had daily or weekly angina, about two-thirds of the times the doctors got it right. But a quarter of the time, the doctors actually said they had no angina. That means that the patient is experiencing daily or weekly angina, and the doctor thinks they're angina free. And the overall concordance was about 0.48. And so we thought, well, why is it that doctors aren't accurately capturing patients' angina? Like, why are they under-recognizing angina? So we as hypothesized that doctors would under-recognize angina in women, in minorities, and older patients. And when we looked at a logistic regression predicting the under-recognition of angina, none of that made a difference. What really made a difference was the doctor who saw the patient, meaning that on average, the same patient going to two random doctors in this study were 2.5-fold more likely to be under-recognized by one doctor versus another. And this is sort of the underlying data that shows that. So across 15 doctors that saw 10 or more patients, doctor number one never underrecognized their patient's angina, and doctor number 15 underrecognized 85% of their patients' angina. And, this makes sense. Some doctors get a good history, some don't, but we never sort of challenge that. And so this highlights how actually collecting the data directly from the patients can give a more accurate and reproducible estimate. And in fact, what happens if you don't accurately recognize the severity of angina? You don't treat. And so we looked at what was the predictor of not increasing treatment. And by far, underrecognizing angina was the leading reason why another diagnostic test or escalation of anti-anginal or referral for catheterization did not occur. When doctors have access to the patient's KCCQ score, it also improves their ability to assign the New York Heart Classification. So, a colleague of mine, Alex Sandu, did a randomized trial of, uh, 1,000 patients, 900 patients. Half the, they all filled out the KCCQ. Half the doctors uh, uh, had access to the KCCQ, and in half they did not. And the correlation coefficient was much higher when the doctor saw the KCCQ versus when they did it. And so, looking at the patients who were assigned a New York Heart Class 3 by the doctors, in the dashed blue are uh, the population density of the patients who reported KCCQ scores from 0 to 100. The green bar is sort of the range that we normally think of as representing class 3. And the black line is when the doctors had access to the questionnaires. And what you see is that there are a much greater proportion of patients called class 3 by their doctors in the range of 30 to 60 in the when the doctors had access to the questionnaire, whereas when the doctors did not have access to the questionnaires, some doctors were calling patients with scores of 80 and 90 class 3. And that sort of says that this can help augment the accuracy of assigning the New York Heart Class when the doctor has access to the patient's self-reported health status or when they don't. Uh, we do a lot of tests to risk stratify prognosis, stress tests, BNPs, you know, uh, cardiopulmonary exercise testing. And yet, these simple questionnaires are incredibly powerful discriminators of prognosis. So this was one of the earliest studies looking at the KCCQ. We lumped patients into ranges of 0 to 25, 25 to 50, 50 to 75, 75 to 100. And this is the rate of cardiovascular death or hospitalization. And at 6 months, less than 10% of the patients who had a score of 75 or greater had died or been hospitalized, compared with almost half of the patients who had a score less than 25. And when you do a multivariable risk model, the strongest predictor of death and hospitalization turns out to be patient-reported health status. Now, people talk a lot about sort of, I don't need this, I've got the New York Heart. This was an outpatient study of 5,000 patients looking at the sensitivity of changes in patients' health status by the New York Heart and the KCCQ, and also the association with subsequent death and hospitalization. And what you see is that when you're evaluating patients over a year with New York Heart, over two-thirds of them do not change New York Heart Class. But when you look at the KCCQ, a stable score is, -5 to +5. There is essentially only about a quarter who are stable compared to the two-thirds with the New York Heart. And you see a lot more discrimination of people who got worse and who got better. And when you look at its association with subsequent death and hospitalization, the KCCQ is significantly associated with death, hospitalization, or the combined endpoint, but the New York Heart is not. So this is a lot of what we do in medicine overall, but in cardiology. And the underpinnings of precision medicine is the idea that we can identify which patients benefit most from treatment, and we can use that information to explain to patients why they should be treated with treatment A versus treatment B. And when you think about unstable coronary disease, what are we trying to do? What are we trying to accomplish by treating patients? Well, certainly we're trying to make them live longer by preventing further progression of their disease, preventing heart attacks or death. But we also want to make them feel better, to alleviate their symptoms, improve their function, and optimize their quality of life. And when you ask patients, they often care more about feeling better than living longer. So I was involved in the design and execution of a study called ischemia. And so at the time that ischemia was launched, there had been some convincing observational data that revascularization markedly improved the survival of patients who had high risk stress tests, more than 10% of the myocardium being ischemic on a nuclear stress test. And medicines might have been better for people with less burden of ischemia. So we identified patients with high risk stress tests, and they were randomized to either go to the cath lab and get angioplasty or bypass surgery along with optimal medical therapy, or to just get medical therapy alone. And then we followed those patients for clinical events, death, MI, uh, uh, heart failure, hospitalization, sudden cardiac death, as well as their symptoms and quality of life. And when the results came out, there was absolutely no difference in the clinical event rates of those managed invasively or conservatively, and the mortality curves are completely overlapping. In contrast, there was an improvement in their quality of life as assessed by the Seattle Angina Questionnaire. And so you think about, well, how would I identify the best patients to send to the cath lab? And all of the traditional risk factors looking at the clinical event rates did not show any heterogeneity of benefit going to the cath lab or not. And in fact, the entire study was predicated on the magnitude of ischemia. So when the core lab interpreted the study, even though they were all supposed to have moderate or severe ischemia, some were mild. And what we found was even in the patients managed medically, that there was no difference in the 5-year event rate of death, MI, unstable angina, heart failure, and sudden cardiac death uh, between those who had no or mild ischemia versus those who had severe ischemia. So the entire foundation of this study was on the concept that the stress test could risk stratify who benefited, and that didn't show any significant heterogeneity to say who should go. What did show a big impact was their baseline angina. So the x-axis is the Seattle Angina Questionnaire angina frequency score, and it's categorized into daily, weekly, monthly, and no angina. In red is the proportion of patients who are angina-free if managed invasively, and in blue are the proportion who are angina-free if managed medically or conservatively. So if a patient is in clinic and they have a FACC angina frequency score of 50, they have a 15% chance of being angina-free 3 months later if they're treated with medicines alone. They have, however, a 45% chance of being angina-free if they go to the cath lab. That absolute difference of 30% is so large that every 3 patients you send to the cath lab with a baseline FACC angina frequency score of 50, one would be angina-free compared with being managed medically alone. In contrast, if they're angina-free at baseline, there is no difference, and the number needed to treat is infinity. And this relationship holds at 12 and at 36 months. So we built the entire ischemia trial on the concept that the critical tool to risk stratify patients for invasive and conservative management is the stress test, when in fact it's probably a 25-cent, 7-item Seattle Angina questionnaire. The guidelines took the ischemia results and updated them in 2021. And in their top 10 take-home messages, their number one or number two recommendation was that treatment decisions should be patient-centered, incorporate patients' preferences and goals, and include shared decision-making. How are we supposed to do that? How are we supposed to take the results, which give population averages in the ischemia trial, and apply it to an individual patient? And what is even the information that patients want to help understand so that they can accurately express their preferences and their goals and participate in shared decision making? So we did a extended study where we wanted to create a one-page decision aid that incorporated the findings of the ischemia trial to support shared decision making. And so phase one was to do a lot of qualitative interviews with patients to identify what are the most important outcomes and how can we present that in a way that makes it understandable to you if you're deciding between going to the cath lab or not. And so what we learned was that most importantly, patients valued quality of life and longevity, followed closely by function and symptoms. After that came heart attack, and way after that came things like repeat procedures, bleeding or kidney complications, etc. And so the things patients said were, forget longevity, it's the quality of life today that matters. I don't want to die. I want to live and see my grandchildren get older. I want to see my daughter live her life. That's supporting longevity. The function was a patient like this saying, the feeling of being able to walk 45 minutes again and I feel stronger as I'm walking, that's a joy that you take for granted until it's almost taken away from you. I've never had another chest pain, nor do I ever hope to get another one again. This is what patients want to know about if they have to decide whether to go to the cath lab and get bypass surgery or angioplasty. And yet we as clinicians are ill-equipped to share that with them. We also want to figure out, like, how do you present data to patients, and we looked at like speedometers, we looked at these health meters. Traditionally used to use those 100 patients, and some would be red and some would be gray. And that was what actually patients did not like at all. And, we then took that information, we iteratively tested and redesigned the presentation. We got feedback from the steering committee of ischemia for practicing surgeons and cardiologists at several different institutions. And then we created a final sort of tool that allows you to answer just a few key questions that differentiate the projected outcomes, including the baseline Seattle Angina Questionnaire Angina Frequency Score. And you get a one-page tool that looks like this, that sort of explains to patients what coronary disease is, how it can be treated and what some of the risks are. But importantly, it says how many patients are, there's no difference in survival, but what your quality of life is today on the left versus in the middle, what it would be like with medicines alone versus what it would be like with medicines plus going to the cath lab and getting revascularization. The same for physical functioning and the same for angina. It's better for in this patient for going to the cath lab, but maybe it's not so much better, and maybe the patient would prefer to try medicines first, and if they don't get a good success, then move over to an invasive strategy, because there is no difference in survival. And this is available at myhealthoutcomes.org, and you can download it and use it in clinic tomorrow. When you decide to treat a patient, monitoring their response to treatment, I think, is an underused benefit of using these tools. So there's lots of new heart failure treatments, SGLT2s, GLP-1s, Versigua. They all have relatively similar relative risk reductions in death and hospitalization. So why not base using these therapies or adjusting these therapies on the impact on quality of life? And in fact, you can quote unquote test this by giving the patient the KCCQ before and after treatment. And if they get better, you continue the treatment. And the patient, by seeing that they got better, is likely to now understand why you're treating them and will likely be more adherent to the therapy. Or if they don't improve, maybe they'll try something else. So schematically, you got a patient, you give them the KCCQ, you then intensify therapy, you do a follow-up KCCQ 2 months later, and if they're doing better, you keep the therapy, and if they aren't doing better, then maybe you try something else. Pretty simple. The it also has a similar impact in population health management. Nothing altered the consideration implementation of telehealth like COVID-19. This is a study we did in heart failure at our institution before and after COVID. So in 2018 and 19, we had 100% in-person visits and we had no telehealth visits. But in 2020, we had almost 90% telehealth visits. And you can see the average number of office and telehealth or virtual visits and how they just flipped on a dime as soon as there was the national shutdown for COVID. However, as soon as that ended, we started going right back to office visits. And currently, over 95% of our visits are in person. And the question is, does that really make sense? I mean, a lot of times, if our patients are doing well and they just need their meds refilled, wouldn't it be more convenient to the patient to not have to spend the day coming into clinic, finding parking, waiting around just to do something that could be much easier, more easily and efficiently handled by phone or by visual conference? And so why not do a KCCQ before their visit? And if they're not worse, their score is above -5 from the last visit, do a telehealth visit. They're stable or better. If they're doing worse, then bring them in. And to me, that seems like a very rational way to more efficiently manage patients and would be better and a better patient-centered experience for patients themselves. I talked about the ischemia trial and the lack of sort of benefit of doing invasive management in patients with no angina. And, you know, some people sort of categorize me as being anti-intervention. And that's not the case. I think that we should be interventional and aggressive in treating patients who will benefit. And this was a very interesting study asking patients in primary care clinics throughout all of Australia. They had 207 primary care practices. They had that the next 10, 20 patients who came through clinic with coronary disease, whether they came for their coronary disease or for a flu shot, give them the FACC. They looked at how many had weekly or more angina, and they looked at the percentage of each patient's practice of ischemic heart disease patients who had weekly angina. And this is what they found. And this is unbelievable variability. So certainly there's a bunch of clinics where none of their patients had daily or weekly angina, but there are also a bunch of clinics where more than half of their patients had daily or weekly angina. Have those patients seen a cardiologist in the last 5 years? To me, population health management would be about identifying these patients out there who have a lot of angina, who might really be benefited from a careful evaluation as to whether or not we could offer them additional treatment, a cath and revascularization or a workup for vasospasm or anoka. But these are patients suffering with a lot of angina who nobody's addressing. These are just random patients in primary care clinics. And finally, there is an increasing movement to make PROs a foundation of healthcare quality. In this 150 center outpatient study of 5,000 patients with HFrEF, we looked at across each practice, like in the Australian study, how many had excellent health status. And then we adjusted for 28 patient characteristics to look at the variability across centers. And what we found is there were some clinics who had none of their patients with the score over 75, meaning with good to excellent health status. And there were other clinics where almost 80% of them had good to excellent health status, such that there was a 70% greater likelihood of a statistically identical patient being treated at one random clinic in the study versus another, having good to excellent health status if they had been treated at clinic A versus clinic B. And so, this to me is why people have really been thinking. I mean, if you're going to judge the quality of care, how well your patients are doing seems to be a very natural outcome to measure, but we currently haven't done it. There have been efforts, in fact, there are already LOIC and CPT codes available. Every time you use a FACC or a KCCQ in clinical practice, the clinic gets $3 from Medicare and $11 to $16 for private practice, commercial insurance. And if a doctor scores it and discusses it with a patient, they can elevate their EM code, but it's still never being used. The National Quality Forum endorsed these measures, but then retired them. CMS had developed the FACC as a performance measure for PCI, the KCCQ for chronic heart failure, but that was just before Price took over in Trump 1.0, and then that all got canceled. The ACC has recognized the KCCQ as a quality metric, and the International Consortium for Health Outcomes Measurement has recognized this as a key measure of value. So, to me, if PROs can increase the accuracy and efficiency of care, they can risk stratify prognosis and treatment benefit, monitor response to therapy, and may ultimately be a requirement to quantify the quality of care. We should be integrating them, but how do you do it? When you ask patients, and this was done by Joseph Stellick at the University of Utah, where they implemented this in heart failure care, and asked them, like, what do they think about collecting the KCCQ? So they did a qualitative study of 24 patients, and 23 of the 24 strongly agreed that the PROs gave their providers a better sense of their heart failure and how they were doing. 16 thought it was helpful in their communication with their doctor. 22 actually felt it improved the quality of care that they got. And yet, two-thirds of them said more attention should have been given to their KCCQ scores. Basically, patients feel that the use of PROs are important, particularly if their doctors use and discuss them in clinical visit. I talked about Alex Sandu's study earlier on at Stanford. He did a lot of qualitative interviews with providers on using these. And so, what was important in supporting implementation of it? And providers highlighted how important it was to have a clinical champion who was really supporting them in understanding and using it throughout the process. They thought experience was key. This was what one provider said. Yeah, I was going to say, obviously, the more you use it, the more comfortable you get and the better you understand what each individual score means, because you've been in more and more positions when you've seen a score in that range or you've seen a score and heard a similar story. Nobody intuitively knows how to read an EKG until they practice, but then they start to be able to understand the patterns and read it better. The more you use it, the more helpful it is. integrating it into workflow. Initially it was time consuming compared to what other tools we have, but now when I look at it, I don't think it's time consuming because the information we gather is so valuable. Having the score show up in Epic is fine because it's easy for us to kind of locate it, and to put it in place when we open the charts that we see it is very helpful. you know, Providers felt it actually helped them improve care. I think it's very helpful. I think it's very helpful because, like I said, I think that my history taking can be a little bit variable from how the APP does it, from how someone else does it. But I think the nice thing about the PRO is it standardizes that to a larger extent. It's better communication. Here's somebody who said the times that I look to see a way if there's anything that's changed from their baseline. And if I know the patient well and they've never had issues with fatigue, and all of a sudden they've been fatigued for the last month, I would then make sure that I address that in a more detailed way. This is like that efficiency concept I talked about earlier on. And here's a doctor who thought, it was very helpful to engage patients, to explain why they were doing the therapy because their current quality of life is X, and they thought they could get it to Y if they took this new therapy. Now, I told you that this was a randomized trial, and so half the patients it was routinely used. So whenever they showed up, they got a KCCQ, and that KCCQ was shared with the doctors. And half the patient was done at baseline and a year later, and not at all during the year. And so the primary outcome was a change in KCCQ. And what they found was absolutely no difference. And basically across all the KCCQ domains, there was the overall summary score was 0.2 points different, higher in those where the PROs were used, where they were not. However, there was a very important interaction that they discovered, and that was that they independently asked patients how, whether they providers whether they used it routinely or not. And half the providers did not use it, and half the providers did. And there was a significant interaction such that the health status was about 5 points higher over a year. The improvement in health status about 5 points higher when the doctors actually used it than when they did it. And this obviously makes a tremendous amount of sense. How can a tool work if you don't use it? And so, again, this highlights the need to really have people understand and use the tool. So, if you're going to think about implementing something like this, you have to have a clinician to educate and to help support and hold others accountable for using it. You have to define and really think through how to best collect it. Is it through portals? Is it through text messages? Is it through in-clinic tablets? How are you going to present the data? This data has all been presented primarily to doctors. Should we start presenting it to patients? And then, how in the EMR are we going to actually fold this in so that it's readily done? My view is that, once you try it, you're going to like it. That it takes a while to get used to doing things and practicing differently, but it's very valuable once used. So I hope that through this talk, I've been able to adequately define the advantages of systematically assessing patients' health status, function, and quality of life, to more consistently and efficiently monitor their cardiovascular disease and its response to therapy, to identify the opportunity to leverage health status prediction models to support evidence-based, patient-centered shared decision-making, and how they can be implemented in routine care. And if you'd be willing to evaluate this session, I think the sponsors would very much appreciate it.
John, thank you so much for coming and presenting to us. That was great. I love your take on personalized care, and thinking one of the things that you said that struck me, and again, while people are thinking about questions that they might have for you, and just want to make a plug to please put your questions in the Q&A. Um, we as providers order a lot of tests. I think you alluded to that. More and more we rely on tests, not just in cardiovascular medicine, but in a lot of subspecialties. And really what you're a big part of the concept that you were talking about is, incorporating patient preferences and goals as we think about how we need to work up, diagnose, and treat patients is really important. One question that came to mind is, we're a broad audience here today. Chest pain or angina, it's not always straightforward in clinic, especially in primary care clinics or maybe even in a specialty clinic that doesn't necessarily focus on cardiovascular medicine. And I've used some of these scales in both practice and research. But what do you have any comments about, could these tests potentially be, or not tests, could these surveys, if they're used on the wrong patient, could you potentially lead yourself down a rabbit hole that maybe you don't want to go down if it's not being used correctly? Do you have any thoughts on that, or has that come up
Well,
in?
yeah, I mean, it's an interesting question. I mean, so these tools are, and I do think of them as tests or assays, and somehow when we call them questionnaires, we're denigrating them, but they're, what's the hardness of a test? It's, do you get the same answer the same time, over time, every time, if the whatever you're measuring hasn't changed, and does it respond well to change, or does it, risk stratify? And so these things do that better than almost anything. And in fact, the test retest reliability of the KCSQ or the SAC is like, 0.9, 0.92. The two different doctors, the kappa, the correlation between two different doctors interpreting the stenosis on a coronary angiogram is about 0.54. And that's not two different angiograms, it's the same angiogram. And if you look at the same doctor, the correlation of interpreting the same angiogram 6 weeks apart, it's about 0.7, a lot lower than these PROs. But yet the angiogram's hard data and the Seattle Angio Questionnaire is not. Now, these things are not to supplant clinical judgment or care. That's the key issue. They are to augment and help us more sensibly measure something. So, if you give a SAC to somebody, if you give a KCSQ to somebody with bronchospastic asthma, you're going to end up measuring something that can be measured by the KCCQ, shortness of breath, but your treatments will be all wrong, right? And so you've got to apply the test in the right person. And, this is what we do to everything. I mean, if the pretest probability, the interpretation of a test with a high or low pretest probability is very, very different. And that's, requires judgment in, sort of applying it correctly. Interestingly, the KCCQ has been adapted for renal disease, for pregnancy, for pulmonary hypertension. And in pregnancy, which is really interesting, the people who have, pregnant people will have scores in the 80s or 90s, which would be a lot lower than they would have in, before they were pregnant. But people who have pregnancy and peripartum cardiomyopathy have scores in the 20s and 30s. So, yes, there can be some population specific differences if you're not applying the tools to the right population. But I don't think that, you would, just like, if you have a 24-year-old showing up in the ER with chest pain and the ER doc gets a troponin and it's 45, you're not going to say, oh, they're having an MI. These are, there's a lot of judgment in interpreting the test in the right context. And if you misdiagnose, then you're going to get interpreted incorrectly, but that's independent of the test itself, I think.
Thanks, John. A really helpful answer, and I still don't see any questions in the chat. So, I have tons of questions, so I'll just keep asking, but would definitely encourage audience members to put their questions in the chat. One of the things you talked about is using some of these tools up front to try and triage people, and help with figuring out, how to best manage them, either via telehealth or if they should come to in-person clinic. Thinking about that, going one step further, has there been anyone who's looked at using these tools to help triage patients who should be referred from primary care to cardiology or cardiovascular medicine? And the reason I bring that up is because obviously we see a lot of angina, um, but primary care can do a great job managing angina. And in most stable angina cases, time is on our side, right? It's not an NSTEMI. We can up titrate anti-anginal medications without putting our patients at significant risk. But could we potentially help
Uh-oh. Well, I hope
Looks
medicine
he
looks like he
clinic?
got a little
he
frozen.
froze, but I can answer the question as long as you can hear me. So the in the population health slides, I was trying to bring some of that out. Like I think that it would, in a health system, I mean, UW had, your health system has a very large reach, I assume, and lots of sort of primary care clinics, etc. And so you could consider surveying the patients to find patients with a lot of angina and proactively reach out to their primary care doc to see if that they would help. Conversely, I think you're right that a lot of internal medicine and family practitioners can do a great job managing stable coronary disease. And the ischemia tool, if you get a positive stress test, that does not necessarily mean you have to go straight to cardiology. In contrast, the ischemia shared decision-making tool should empower a primary care doc to say, there was some evidence of not enough blood flow getting to the heart. We can, treat this with, statins, your blood pressure, anti-angiogenic medicines, etc. Or I could refer you to cardiology to go to the cath lab. And here's what the outcomes would be after a year if you did or didn't go to cardiology in the cath lab. And if, we also have the opportunity to try medicines for 3 months, and if they don't work, then refer you. But if you get complete relief, not refer you, and it's going to have no difference on your rate of dying or heart attacks. I mean, that would be a very empowering tool for primary care. So one example is primary care doing a bad job managing angina. The other is primary care having the opportunity to do a much better job doing shared decision making and meeting the patient's goals by treating them, with optimal medical therapy, and they don't need the expense, hassle, burden, or risks of going to cardiology and the cath lab if they get a great response with medical therapy alone or angina free to begin with.
Thank you. Yeah, that's really helpful, and I think definitely some opportunities for us here at UW to improve across the spectrum of primary care and subspecialties, and really again get back to that age-old adage that history we can learn a lot more from history than oftentimes physical exams and tests, especially if we take into context what people really want out of their treatment. So thanks
We
thanks
also
for reminding
realize,
us of that.
how dysfunctional healthcare reimbursement is, right? Like if you, it's always funny to call it UW because I went to the University of Washington, Seattle, so it just feels weird to me. But at UW, imagine if you were paid, you're managing whatever, 5,000 coronary disease patients, and somebody gave you a budget of, $50 million to manage all those patients, how would you manage them? I mean, immediately you would probably stop doing stress tests, right? You would be doing CTAs, you'd be monitoring them with a FACC, you'd have cardiology doing primary care consults when patients had angina, what the next step is. I mean, our whole practice model would be different. Why in my institution did we go from 90% telehealth to 100% inpatient visits when everything, left? Because we get paid more and we built all this infrastructure of MAs and clinic space, and we got to use it, and depreciate it. So, these kinds of ideas, I think, offer the opportunity to engage in very different models of healthcare delivery, and they are not perfect. Like look, and the other thing that I just want to highlight is that, uh, I showed you amazing data about how much better doctors classified NYJ when they had the KCSQ, or how uh, a quarter of the time that doctors said the patient had no angina when they reported daily or weekly angina. It implies that the doctor's a bad historian, but sometimes the patients don't tell you. So a great anecdote is the first person to ever use the KCQ clinic was a guy, and this was in '98. And he put it on a Scantron. So people would fill in the dots. And he before he could score it, he would just look at it. And the worst scores are on the left. So when he would look at a score, if there was a shift to the left, he knew the patient wasn't doing well. And so he has this lady, this 75-year-old woman comes in and says, "Oh, Miss Jones, how you doing?" "Oh, I'm doing great, Dr. Porter." "Oh, really? Any shortness of breath or, difficulty climbing stairs?" "Oh, no, I'm just fine. Thank you, Dr. Porter." And he says to them, "Well, ma'am, you filled out this questionnaire and it says you're having shortness of breath a couple times a day." "Well, yeah, I guess that's true. And then it's very difficult to climb a flight of stairs." She goes, "Yeah, I wait for the elevator now." "Well, why did you tell me you were doing so well and had no shortness of breath or limitation?" She says, "Oh, you're such a good doctor, Dr. Porter. I just didn't want you to feel bad." So, sometimes patients don't share exactly how they're doing. I talked about clinical efficiency. I mean, the other day, one of my colleagues came up and he asks an old farmer how he's doing. He says he's doing great. And he looked at the score and he knew he was not. He asked the wife, how's he doing? She says, he hasn't left. Is that true? How's he doing? She says, he hasn't left the couch in a month. And so, these things, I don't want to come across as criticizing doctors as historians, but using tools like this can give us a much more accurate, reproducible picture than the way we've always done it.
Yes, and people do minimize their symptoms, and sometimes as patients, and sometimes as doctors, we hear something, but we're also sometimes maybe want to minimize to make people feel better. And again, like thinking about all of these arbitrary cut points that we have, like, oh, you're a good doctor if you can get somebody's A1C below X, Y, or Z, or you can get their blood pressure down to X, Y, or Z, when the reality is, if those cut points aren't in line with the patient's goals and preferences, we're doing no one a service. We're just trying to complete a metric. So it really does make sense to me to use these tools to help think about how we're delivering, not just how we're delivering care, but actually how we're implementing care and how we're impacting our patients' lives. So John, we're almost to the top of the hour. I loved having you join virtually. I wish you could have been here in person so we could go back out to the bar. But this was absolutely lovely. Any last words for us?
I really appreciate it. I hope it, provokes some new thinking that goes on in your clinics and practices, and that you'll reach out to me with any questions or if there's anything I can do to help.